Today on the Blessing Health System podcast, we have Blessing audiologist Carly Williams joining us today. To kind of get started, what drew you to audiology and how did you get your start?
Yeah, well, thanks for having me. Audiology really became more known to me during my schooling. So I went into undergrad knowing I wanted something in the communication disorders realm. And in taking classes, I really was a lot better off. I enjoyed the audiology courses a lot more than the speech pathology courses. And so I just kind of fell into it that way and went to grad school after that, and I'm very happy that I did because it's been a great journey for me.
What are some of the key things we should be looking out for when it comes to risks for hearing loss, loud music, that sort of thing?
Yeah, so a lot of people think just, I don't do anything loud, so I'm protecting my hearing, and it's loud isn't as loud as you think, I guess is the first thing I would say. And so knowing you can use your smartphone even there, you can download free apps to do, like a sound level meter.
Yeah, I had one in my AirPods.
Yeah.
The AirPods always went off all the time when I was driving, stuff like that, yeah.
Yeah, or my watch, will do that. If I'm at a concert or something, it'll say, hey, it's too loud right now. And so knowing how loud your environment is the first step, and then knowing how long can I be in this environment with or without hearing protection before I'm doing damage. And then other risk factors aside from noise are just your overall health. So a lot of people don't know heart disease can put you at a higher risk for hearing loss. Anything really that affects the blood, diabetes, kidney dysfunction. And then there are things that we can't control as much like chemotherapy, genetics. So lots of factors play into hearing loss, and sometimes we don't know what caused your hearing loss. It's usually a combination of things.
So when you talk about the blood disorders, that sort of thing, is that blood flow getting to those muscles, or how does that kind of work?
So in the inner ear, the cochlea is the organ for hearing, and it's highly vascular. And so anything that can affect the blood can affect that organ, and then eventually trickle down to affect your hearing. And same thing with nerves. Parkinson's, for example, can affect your nerves, so can MS, and that can affect the auditory nerve, and that will also affect the signal that's going up to the brain, and that can affect your hearing in a different way.
What are some of the tell signs for, let's say, you have an older parent or grandparent or something that you're looking out for, and you think that they might be experiencing hearing loss? What are some of the early signs or just signs in general for you to be able to tell that?
Well, one thing I think it's important to note is a lot of the signs of hearing loss are similar to signs of dementia. And so sometimes people will think there's something going on with memory and things of that nature, and it's actually because the person didn't hear. So they didn't hear what time they were supposed to be at that event or what have you. And so if you're starting to think one route, think the other as well, and just maybe get evaluated for both. And also hearing loss puts you at a higher risk for dementia. Untreated hearing loss does. So if you're just thinking, hey, someone's not hearing me as well, the signs really are more when I'm sitting in a room that's quiet one-on-one, maybe I hear fine. But then when there's a group of people, I'm starting to struggle more than I used to. Or a lot of what I hear is, I hear fine, I just don't understand. And so a lot of hearing loss starts in the high pitches, and that's where we get the consonant sounds like S, T, K, F, SH, all those really soft sounds that when you're in a noisy environment, if someone is compensating for that noise by raising their voice, you can make a low pitch sound like ah, you can make that very loud. But a sound like T, you can't really amplify that too much over its original sound. And so those get lost. And it starts to make it sound like people are mumbling when they aren't, which is how it's easy to deny that you have a problem, right? Because you think, oh, it's everybody else. They're all mumbling. Nobody enunciates these days, those darn kids. So, it's not always just loudness. It's clarity as well, and mistaking certain words for another, obviously asking people to repeat. But the clarity is probably the number one way I think hearing loss sneaks up on people because they hear some things just fine. Their low pitches may be fine, but the high pitches are already starting to go.
So is there a certain, and that kind of is similar just from my thinking of like vision. where some people are far sighted, some people are nearsighted. Is there a certain age that you can start to see a lot of patients where after, I don't know, 30s, 40s, maybe in certain fields, like my brain goes to maybe manufacturing jobs with loud machinery constantly. Is there a certain age range, or does it depend on occupation, lifestyle?
Yeah, it depends on so many things. So, we see kids that have hearing loss, we see teenagers and young adults, and because genetics plays a factor as well, it can really vary as far as age goes. But obviously, the longer you're in a manufacturing job, for example, when you're in or my farmers that come in, they're going to have hearing loss sooner than a peer that has the same sort of general health background but maybe has an office job.
So if you think that you're at risk for hearing loss or a loved one's at risk for hearing loss, what are your next steps?
So my first recommendation would be to get a hearing test, which I think a lot of people don't always do right off the bat. Maybe they'll mention it to their primary care, and that's great. Your primary care is a good referral source that can send you in the right direction. And coming in to just get a baseline, I think a lot of people are scared to do that because there is so much information out there on the internet, on commercials about hearing aids, and it's really in your face. And so they think they're going to come in and get a sales pitch rather than, just information about their health. They think it has a little bit more of a stigma because of that. And so really just getting a baseline hearing test. And if it's normal, great. That's what we want, right? If it's not normal, it may not be to the point where you need hearing aids yet. And then hey, let's come back in a year and track this and see how it's progressing. Or maybe you're at the point where you already need hearing aids. Most people, it used to be, this has gotten better, used to be an average of 10 years that people would wait before feeling like they had hearing loss and actually going to do something about it. And now it's more like 4 to 7, depending on the research that you look at.
Whenever somebody does go in for that original test, what does that look like typically? I remember in school we used to do where it was different pitches in different ears with the headphones.
Right.
And do you is that how you get some of your younger patients, is through those tests? And then as you get into adulthood, is it a similar kind of test?
Actually, yeah, the kind of gold standard for audiology, just a regular audiogram that you would come in for your baseline hearing test is going to be pretty similar school age through adult. Obviously for younger babies and things, we have to do more objective testing, but you're going to be putting some headphones or earphones in. We'll look in your ears first, make sure you're not full of wax. Have you listen for tones, press a button for the tones, repeat some words. We do word testing at soft levels and then louder volumes. And then we put bone conduction on, so that's a headband that goes behind your ear, and it would bypass anything, for example, if you had fluid in your middle ear space or a hole in your eardrum that's causing some hearing loss. It bypasses that and goes right to the inner ear, and that gives us a type of hearing loss, which will help us know, is there anything maybe medically that can be done for this hearing loss, or is it permanent and it's all in the inner ear and hearing aids are really going to be the only option.
So outside of hearing aids, what are some other options for hearing loss?
Yeah, if you're just a kind of in the borderline zone, which I have people come in sometimes that are just really aware of the fact that their hearing has changed some, but they're not at the point yet where hearing aids are really cost versus benefit wise going to be the best solution for them. You can look into over-the-counter devices and also assistive listening devices. And so those are kind of two different categories. Assistive devices would be something like TV ears, right? Where, I hear most of the time I hear fine, but my family's mad when we watch TV, it's way too loud for them. You could get a device that plugs into your TV so that it goes right to some headphones for you and it's a little bit more clear. Even iPhone, if you have an iPhone and AirPod Pros, you can download an app to do a hearing test on your iPhone and plug that into the health app. And then the AirPod Pros have a certain amount of amplification that they can give. And so if I have somebody that, even someone with normal hearing comes in, but they're struggling in noise, that could be something that we try where they just put their AirPods in and it has a little bit of that noise cancellation, and that can help in that environment. But over-the-counter hearing aids are a whole different category than those options.
So yeah, getting into the hearing aid specific So you determine somebody needs hearing aids. What does that process look like? Is it similar to like a prescription for getting glasses, or is it a whole different thing?
Yeah, I wish it was similar to that, but no. So we take the hearing test, and based on that test, there are different fitting algorithms that we can use, and there are different prescriptive methods. And so, based on the test, depending on the age of the person, even their hearing aid experience, we'll use a prescriptive target, and so a different amount of gain or amplification at each pitch based on the hearing loss at that pitch. And that's not always the end-all be-all, because sometimes you can have other factors involved, like if someone's really sensitive to loud sounds, even though they have hearing loss, your range of where you can fit that in is going to be a little bit smaller. And hearing aids also aren't just, let's just put them in, they're set, everything's crystal clear, it's good to go. It takes some more time to adapt. So I usually relate it more to something like getting dentures. You know, when my patients who have had dentures, they know that it takes a little time to get used to, it's worth it in the end, but they have to adjust to having something new to work with. Hearing aids are a little bit more like that, where your brain has to adapt to this new way of hearing, and it's not always ready for the full target, the full prescription on day one. Sometimes we have to work up to that.
So is it even, I'm guessing it's also like the feeling of having those on.
Yes.
Like over time, it would just be another thing that you're used to, like contact lenses or something like that,
Right,
for
or getting a
example.
new watch, you know, all of a sudden you feel, or a new pair of glasses, you know, that's one thing I often say, well, if you have a new pair of glasses and it's rubbing behind your ears or on the top of your nose and you just kind of are aware of them, but it gets better and better every day, that's how hearing aids are.
So when we're comparing prescription hearing aids to some over-the-counter solutions, how do you explain that to patients that might be considering going with, I can just go get this at the store?
Right. It's a really common question. As I said before, it's very confusing for just the general public, even providers that aren't in the audiology sector. It's confusing because you have a lot of different options. And so there are over-the-counter hearing aids that are low-end over-the-counter. There are high-end over-the-counter where you can actually put your hearing test into it. And then there are prescription hearing aids where you're coming in and someone's actually programming them for you. So the big thing is to know, are you a candidate for over-the-counter or not? So I think over-the-counter can be great for the right population and the population it's meant for, which is over age 18. Obviously, no medical needs for the hearing loss. You're not having somebody who is full of fluid just go get a hearing aid instead of going and getting a tube in their ear, for example. But the over-the-counter is for mild to moderate hearing loss only. And a lot of people, by the time they come in for that first hearing test, are already past that point because people wait so long. Or sometimes they've tried those options and it didn't work out that great for them. And so then they come in and we're finding, well, yeah, you were already beyond the fitting range for that option and that's why you didn't like it so much. But if you have just your general hearing loss with aging, you know, sloping mild to moderate hearing loss, an over-the-counter option can be a good fit. And that's something that I will tell my patients. If that's a category that they're eligible for, I'll let them know that. If not, then we move on to prescription hearing aids.
Yeah, I think it's really important that if it's possible to go with over-the-counter, and that's a good fit for them to like, hey, we don't want to feel pressured to go with something that we're prescription, that sort of thing. Whenever we look at more intense cases, and you mentioned some of the medically produced hearing loss, what does that kind of look like if, and I might be misspeaking on the term, but is it cochlear?
Cochlear?
Cochlear. So I've heard of like cochlear implants and that sort of thing. How far into the hearing loss, like I don't want to say spectrum, but like deep into it do you have to get before something like that's medically necessary?
Right. The main thing we're looking at there is your word understanding. So a prescription hearing aid, we can make that louder all day long, right? We can make it very loud if we need to. But the clarity is going to rely on your hearing nerve. to take the sound up to the brain accurately. So what happens over time with hearing loss, if you have enough damage into the cochlea, there are hair cells in there, and if they have enough damage, it's not going to give a clear signal to the nerve. And so then a hearing aid isn't going to help as much as it used to because it has to go through that pathway. It has to travel through those damaged hair cells and get the signal to the nerve that way. A cochlear implant is for someone who does not benefit from hearing aids anymore. So usually they have severe to profound hearing loss in both ears. They have been doing some for single-sided deafness now, but the kind of traditional cochlear implant candidate is severe to profound hearing loss, both ears, and your word understanding is usually 40 or 50% or less. So that means when we speak with recorded speech, so we'll put recorded speech through the headphones at a level that is appropriate and audible for you, based on your hearing test. If you're getting less than half of what's being said, you might be a candidate for a cochlear implant. And there are more involved tests to that. So if we find that you might be a cochlear implant candidate, then you have to go for a cochlear implant evaluation. And that's where they actually do testing with hearing aids on and do sentence testing and testing of noise. That's a kind of long battery of tests that you do to see how much do you benefit from your hearing aids and do you meet that criteria for a cochlear implant.
Cochlear implant would be you can hear the words but not understand them. Is that accurate?
Mm-hmm. Your hearing aid makes things, it's like a distorted speaker. So turning up something that's not clear isn't going to help much, right? Maybe you can get some of what's being said on there, but in general, it's not going to help. And so a cochlear implant, they implant an electrode array into the cochlea that takes the place of the hair cells, essentially. So then it's electronically stimulating the hearing nerve instead of acoustically stimulating it like you would with a hearing aid.
Yeah, I've heard of some sad cases with like younger, like teenagers and that sort of thing needing that, and that's always something that you just don't like to see, especially with youth. So that's not like something that they necessarily did wrong. Cochlear, that's just like genetics and that sort of thing.
Oh, it could be lots of things. So you could suffer a sudden hearing loss. I had a patient that had a sudden hearing loss overnight. Usually that's just in one ear, but this patient had it in both ears. And I believe he was medication related. This was years ago that I'm thinking of this particular patient. But he ended up getting 2 cochlear implants after that. And he did great, did wonderfully with them. And so it can be a blessing to get a cochlear implant because if you were not performing well with your hearing aids, this is going to be a lot better typically.
And so when we think about some of the patients that, when you think about some of the patients that you've worked with, do you have any stories that kind of jump out of like success stories, whether that be with prescription, over the counter, or just, patients expressing gratitude to you? I'm sure that they go through a lot, like multiple different doctors, especially if they've been on hearing aids for a long time. So do any stories like that jump out to you?
Yeah, I have had, with cochlear implants specifically, I used to work with cochlear implants at a previous position, and those are really rewarding. They're challenging but very rewarding cases, and that's when you a lot of times get the tears and I had a patient, his wife hand-stitched me this blanket because she was just so happy with how he was hearing, and just really, it's a sweet, very nice patient population. But the big thing, I think, is just bringing people back into their daily lives. So hearing is really a quality of life issue, and I don't feel that a lot of people look at it that way. Even the patient themselves sometimes will come in and say, well, I hear what I want to hear, And so all those what I love hearing is all those little incidental sounds throughout the day that people are missing that they didn't realize they were missing. Mm-hmm. So even during the very first appointment when I put hearing aids on, sometimes people will go to sign the paper and they'll say, oh, I could hear the pen on the table. Or one time I had a patient say, oh, I just understood why they call it clicking the mouse because it makes a click sound. Or I can hear you typing, all those little noises in the environment that they've been missing out on. And maybe they aren't sounds that everybody wants to hear or needs to hear, but to me, it's just bringing you back into the world of the hearing. I've had lots of different patients say, oh, you saved our marriage because now I don't have to yell at him anymore. So there are, lots of stories, and it's always nice to see when someone's been successful with their hearing aids. But probably my favorite is when I see somebody that has had hearing aids elsewhere and comes in. Obviously, I don't like to see this, really, because they come in and they're upset. These hearing aids maybe, oh, these are a year old. I think I must need new ones because they just never have sounded right. And maybe they weren't programmed appropriately, or maybe they didn't get good counseling, or whatever the reason is. And I say to them, we don't need new hearing aids. These are good hearing aids. It's just that they're not fitting properly. And so then we can kind of reset them. And I think that's when they're the most grateful, is when they come in thinking they're going to be spending out for new hearing aids. And we can do something with their current hearing aids that's going to be appropriate for them and cost way less, which is nice.
Yeah. So to kind of close, what being at Blessing, what kind of strives do you feel like Blessing has made for our patients in terms of audiology?
That's a great question. One, we are the only people in the area that see Medicaid hearing aids. And so we have a big Medicaid population for hearing aids, and those patients are really grateful that they don't have to drive hours away to, well, some of them are driving hours to see us, but driving even further to see someone else that fits Medicaid hearing aids. And so I appreciate that we do that to help that population. And also just, I have flexibility in my schedule to set an appointment time for longer if needed. If I know a patient's going to maybe need a little bit more time on the counseling, if they have neuropathy, for example, and I think they're going to struggle with learning how to put a hearing aid in because they don't have good feeling in their hands, I can schedule longer appointment times. And then also working in a medical office is really nice, because if I see something on that initial test and they aren't already scheduled with the ENT, our ENTs, Dr. Jones and Dr. Mount, are both really good about getting people in that same day. I mean, even today, just today, I had one or two that I said, hey, I'm seeing this patient. They're not on your schedule, but I noticed this on their exam, or their hearing test showed this, and it could be a medical reason for their hearing loss. Would you have time to add them on? And I can't think of the last time they didn't add them on for me. So that's nice, because it's sort of a one-stop shop that way, and we can get them taken care of. And Blessing, even in general, I've experienced with my parents' appointments, Blessing's very good about considering the patient's travel time and getting them in for different appointments on the same day. So my dad was coming down here for two different a radiation and then a surgical, something separate. And they'd say, oh, well, we could schedule your radiation appointment on this day. I see you're coming in with this doctor already that day. Let's just do it the same day. And so I think that's a little thing to us, but it's a big thing to the patient. So I really like that providers do that.
Awesome. Well, thank you, Carly.
Yeah.
Is there anything that I'm missing in terms of audiology that you would like to share?
No, I just think don't be scared to come in. I guess that's my big thing. We're not going to pressure sale you or anything like that. That's not what we're here for. We're here to counsel you on your hearing and treat your hearing loss if you're ready for that. And we will definitely tell you the different options. And if over-the-counter is what you go with, that's fine. And we're here for when you kind of graduate out of that to need prescription devices.
Awesome. Thank you.
Yeah, thanks.